So welcome everybody. I'm Sarah Humphrey. I'm the clinical lead for the Yorkshire and Humber Clinical Networks, and we're a co-producer of this with the London Network. And I'd also like to introduce my lovely colleague Delia, who is a consultant pharmacist at the South London and Maudsley. This session is, we've already launched the toolkit, so this is aimed really at pharmacy or medicines management colleagues, but we're delighted whoever is on the talk today, just so we can have a conversation. So the plan will be that we will just describe the toolkit, have a little bit, do some slides, roughly 20 minutes to half an hour, and then it's really a conversation and a discussion with you guys about what you think and just some thoughts about the appropriate prescribing of antipsychotics. So today we're going to talk about a new toolkit about the appropriate prescribing of antipsychotic medication in dementia. So what we're going to cover today is a little bit about why we've done a toolkit, the licenses in place, the risks, the variation and the complex reasons why we use antipsychotics. And then we're just going to have a brief look through the various sections of the toolkit. We are going to spend a little bit more on the deprescribing bit. Because hopefully, mostly, we've sort of got pharmacy colleagues on, and that's probably where your interests are going to lie. So when can antipsychotic drugs help? So drug trials have shown that risperidone has a small but significant beneficial effect on aggression and to a lesser extent psychosis for people with Alzheimer's. And these effects are only really seen in the period of 6 to 12 weeks, not any longer than that. What antipsychotic drugs do not help with are some of the other behavioural and psychological symptoms, such as distress and anxiety during personal cares, restlessness, agitation, so repetitive vocalizations, which is shouting, walking about, sometimes called wandering, walking with purpose, people who are socially withdrawn, and people who have had changes in their inhibition levels, so doing or saying things that are inappropriate. Those things are not helped by antipsychotic medications, and they need a personalised non-drug approach. Which antipsychotics are used for people living with dementia? So the first thing I'm going to say is we are not advocating any antipsychotics should be used, but I do need to tell you where the ones that have got licenses and approvals. So firstly, risperidone has a license for short-term treatment of aggression in Alzheimer's disease if the aggression poses a risk to the person and has not responded to non-drug approaches. Haloperidol, for some of you have noticed, has recently appeared in the BNF as licensed for persistent aggression and psychotic symptoms in moderate to severe Alzheimer's and vascular dementia, where a non-pharmacological treatment is ineffective and there is a risk to self or others. And you'll notice Alzheimer's here, so not even all types of dementia, okay? Other antipsychotic drugs are used for people with dementia are done so off-label, which means, as you will all know, that doctors can prescribe them or other prescribers if they have a good reason to do so and they follow the rules set out by the GMC. So we're not saying that they can never be used, but that's where the licenses lie. There are risks to antipsychotics, and we're noticing that people are often sort of either unaware or don't know how to quantify those risks. And so there are significant risks associated with them, often forgotten. Risk of death, risk of stroke, risk of sedation, worsening of other symptoms of dementia, risk of Parkinsonism, shaking and unsteadiness, all of these things leading to increased risk of infections, falls, blood clots and ankle swelling. So those are the significant risks, and in the toolkit you'll find more information about how to quantify those risks and sharing risks with others. So one of the reasons why the toolkit was developed is that we have significant variation throughout the country, and where there's variation it suggests that actually people are using other approaches, and we may have different approaches to risk. and how we use antipsychotics. So that variation means there's a potential to do something differently. The big thick pink line in the middle is the national England average, which sits at just under 10%. And so that's the average. So you can see there is some areas that are significantly above that and some that are also below that. Lots of people will remember the call to action 2008. And so levels have come down since 2008, but they've gone up during COVID. And you can see some of the data. It does look like we all did something fantastic in October 21. We didn't. We just changed the way, as we like, to the way that we calculate the numbers. So as well as areas, some variation around the country, I've just put in this slide because it shows that we have significant variation within regions as well, and within localities, ICBs. So I'm coming to you today from a place-based leader also in Bradford, and I belong to the West Yorkshire ICB, and you can see that Bradford's sitting there at 15%, and we're significantly different to our neighbour Leeds sitting there at 5.5%. So again, variation all over the place, and a reason that we can do to show that we can do things differently. So I'm just going to hand over to Delia now, who's just going to take you through some extra bits, and then we'll come back into a bit more about what the toolkit looks like.
Thank you, Sarah. It was just a brief summary on reviewing antipsychotics that I wanted to go through quickly. So this is all from the NICE guidance for dementia. It just reminds people to use the lowest effective dose of antipsychotics in people for dementia for the shortest possible time. And they suggest or guide people to review every 6 weeks. I'm not entirely sure where the 6 weeks came from, but I suspect it's because risperidone is licensed for 6 weeks. For behavioural and psychological symptoms in dementia. But obviously you may need to review sooner than that. So in practice, usually for our inpatients, we'd review within 1 to 2 weeks of starting an antipsychotic, to check for side effects, tolerability, and it can take, 3 to 4 weeks to get to optimum dose and to see whether it's had any benefit. So in community, we normally allow 6 to 12 weeks for reviews. So all our community teams will have Excel spreadsheets. They use a traffic light system. Green means someone's been reviewed in time. Amber, the review's coming up, and they go red if we've missed, the limit for review. So within 6 to 12 weeks, and you can start reviewing from 6 weeks, but you've got up to 12 weeks to get all of our community patients reviewed who are on antipsychotics. And obviously, it's important to stop treatment if the person isn't getting any clear ongoing benefit. We did an audit recently, and 10% of our patients, the prescribers specifically said there was no benefit, but then they continued the antipsychotics. So we've added an alert in our notes to say, are you sure you want to continue? You've just said there's been no benefit. You've not said you're going to increase the dose or stop or anything. You've just said carry on. So we've added this alert just to, trigger the, are you sure you want to keep going? And really, unless there is a severe risk or extreme distress, the recommended default management is to discontinue and to stop the antipsychotic. So whereas with most medication, you're reviewing to carry on, it's really important that every review is really with the purpose to try and stop it if you can. If they're on an optimal dose and there's no benefit, we're trying to remember to think, well, we're reviewing to try and stop if we can. But obviously, don't just send them on their way, stop the antipsychotic and send them on their way. You need to keep monitoring, see if there's any relapse, carry on with ongoing assessments of what factors were contributing to the behavior, continue with the non-drug measures that you were using, and base everything around the person's needs, abilities, interests, etc. And I often get asked, like the person's been on it for 2 years now, is it worth reviewing or is it too late? It's never too late to review the antipsychotic, even if they've not had a review in years, and you see them, then try and review and stop it if you can. And this is really just a quick slide on deprescribing of antipsychotics. Studies have shown that up to 70% of people, you can stop their antipsychotic without any detrimental effects. So it's always worth a try. And at least 2 attempts should be made. So you may try once and they relapse. Don't give up, wait a few weeks, months, and try again. the symptoms are so variable, they come and go, you know, so it is worth trying again a second time, and trying to discontinue then. And, you know, the toolkit helps with deprescribing tables and tools. So reduce gradually, obviously don't stop abruptly unless there's a serious adverse effect. And then obviously you would need to stop abruptly. But otherwise, you know, do it gradually to reduce the risk of relapse.
Thanks, Delia. So this slide is why a toolkit. So what we found is, despite often places thinking there's a single reason that we use antipsychotics at their place, when what we're finding is actually it's really complex, the reason why people have high antipsychotic prescribing at their place, and no place is the same as any other place. We have different resources. We'd have different local attitudes for prescribers. We'd have different community assets to support distress. We have different staffing models. We have different environments, different, you know, community hospitals, no community hospitals. We've all had different training, and we have different systems and processes. So it is not a simple thing to just go away and say to people, you know, this is a bad thing, try and, you know, just get somebody to just do something. It's not like that. So in the toolkit, what we've done is try to gather, and you're not meant to be able to see that fishbone diagram other than see at one place, they looked at the causes of their antipsychotic prescribing. What they found, there was loads of stuff. So what we've done is we've provided some audit tools within the toolkit so that you can go away and look at what's happening at your place. So I can see I've got Bradford colleagues on today, and we started that audit because what we know we're thoroughly on the naughty step at 15%, but what we want to know is why is it happening at our place? So we've commissioned, we've used some monies that we had that we were paying GPs to do something before to really do an audit of everybody living with dementia on an antipsychotic, all 700 and something, and find out what are the local reasons, who started it, how long have they been on it, what kind of behaviours. So that's why we've got a toolkit. I'm going to move on to the next sections, but I just thought a couple of things I just wanted to say to you I don't want to lose. I want us to reframe and rethink about why antipsychotics are started. We often talk about challenging behaviours. I want us to think of it as distress. It's only challenging for the people around the person. It is a symptom of distress for the person living with dementia. And if you think about it like that, you treat and manage the distress, not how it feels to us as people being around it. So that's one thing. Somebody, and they may be on the call today, distress is caused by all sorts of different reasons, and pain is a massive one. Okay, there are bits within the toolkit that talk about pain. So if you go back to thinking about distress and pain and other reasons why you might be distressed, and you might show people your distress, that might help you to understand actually we need a different approach to managing it. We don't just give somebody an antipsychotic if you were in pain and distressed. You treat your pain. So just wanted to say that, because I just think if you don't say that, you go in with the wrong frame of mind. And I love Delia's idea of a traffic light system and spreadsheet. I suspect most of us just don't know of those people, and nobody's monitoring them at all. So the toolkit, what's in it? For section 1, what we've tried to do here is provide so that there is no one bit of this that tells you exactly what you need to do. So what you need to do at your place, work out what's causing it, and then take the bits of the toolkit that you can use that address the bits of your system where you've got the problem. So you're not going to be able to pick out one bit of this that tells you how to do it. You're going to pick out the bits you need. So there's information about person-centered approaches, what antipsychotics are if you need to educate people at your place, bits about delirium. Lots of people have leftover antipsychotics because you were actually treating a delirium, and then bits of information around, you know, the risks associated and things like that. So there's all sorts of information you can use in that section. Section 2 gives you information about non-pharmacological approaches to distress. okay, how you might develop business plans if you don't have support mechanisms for distress within your locality. One example, doll therapy. Okay, so that section is all about those other approaches. The next section is really around de-prescribing. So that's got all that sort of stuff that Delia is talking around about de-prescribing. And now I won't apologise for this, but I've also put in, and I'll be talking to the converted today, de-prescribing considerations for frailty and dementia, because this is not just about antipsychotics. Older people are complex, they have physical and they have mental health needs, but they're also got other reasons de-prescribing. So we're talking about anticholinergic burden, we're talking about stop, we've got concerns about frailty. So I think it's an opportunity to really see it in the round and do a holistic de-prescribing, think about those other things. I know I'm talking to the right colleagues today who will know about that, but there'll be lots of your colleagues who that is just a really frightening concept. And we've definitely talked about approaches, but you will all have your own, and I hope we'll talk about some of those on the talk today. So that section is all around de-prescribing. And again, these are just showing some of the slides. We tried to keep it as slim as possible, but what we've done is try to provide you through to links where you can see support materials. We have put this seven steps to de-prescribing in polypharmacy. Most of you will probably be de-prescribing a lot, but I cannot tell you, and you'll all know, and if we've got any university colleagues on, I work with Bradford University as well, de-prescribing seems to be way more scary for people than starting, whereas really it ought to be the other way round. So lots of support needs to go into that whole approach to de-prescribing. So I hope you'll find some of those bits useful in there. And the final section is around support tools for everything. So what we've tried to do is bring together the tools we've found around the country, the best practice that we've found, all in one place. We've colour coded it so that you will know what's appropriate and what has been aimed at, let's say, primary care or pharmacy colleagues or care homes or people living with dementia and their carers. It won't have everything in it, and we know that. You will probably say, but what about mine? And the answer is we're going to be doing another iteration in about a year. We hope by then we will know what you found useful, what's been developed locally at places because of this and because of the renewed emphasis on antipsychotics. And if you find stuff that you love, that you want to put in here in a year's time, then Colin will give you an email address at the end that you can do that, because we want this to be continue to be current and usable. And that's just showing you a sample of how we've colour coded it and how we've used it. So we've got some more conversations coming up, a bit similar to this, but we've got one coming up in next week around really people, usually mental health providers, because they will have different questions and a different emphasis in their conversation. And then we've got another one in November for community people, really, GPs, community staff, care home managers. You can there's a QR code here with a copy of our toolkit. You can also go onto it. It's hosted on the London network. It is on the Futures platform that we know it's a little bit more difficult to access that, but this goes straight through to the London network. So this is a conversation. It's really informal, okay, and it's just so you can have a question, you can have a comment. It doesn't have to be me and Delia answering it. I know that we've got some really experienced people on here. I can see on my screen Anne, one of my colleagues from Airedale Foundation Trust. So we know we've got lots of experience. So let's just open it up. Are there any? So bob your hand up just so we know if you want to chat, or if you feel that a little bit too shy, you can pop it on the chat box. And let's get talking about the toolkit. Anybody, any questions or any comments? Heather, please do fire away.
Well, I'd like to ask a question of the PCN pharmacists that are on the call, if I may.
Yes.
So I don't know if any of them would be brave enough to answer my question. So in Leeds, we've got quite a good track record on antipsychotic prescribing, and I think that's due to the fact that we've got some brilliant, GP practice and PCN pharmacists in our neck of the woods. And also we had a really good guideline, which I had nothing to do with, which was brilliant, around managing behavioural and psychological disturbance in dementia. So we've had that since 2013, which has been really helpful, I think. But my question really is about what would be helpful for PCN pharmacists. So in Leeds, we have a number of templates. So we have a medication review template, which we try and link things like MedStopper, StopStart, etc. to. And obviously, we've been having discussions about whether to put this toolkit into those templates. So just really interested in what colleagues think about what would be useful to them on the ground.
Okay, so if anybody is from a PCN, is a PCN pharmacist, would you pop your hand up? Heather, I'm going to say that we had the conversations in Bradford, and I know Julia, I think I've seen Julia on from Bradford, but this was before she started. We had the conversations with our PCN pharmacists, and I think it was overwhelmingly a little bit trepidatious about the thought of it, weren't they, Anne? It was like, oh my goodness, you're expecting us to do that. And one of the things that we found that we thought might be useful in Bradford was doing it as a bit of an MDT. So we're thinking about having very senior people like Anne, like Jaspreet from our care trust, being available to have discussions with. So you're not doing this alone. This is not your job to do because unfortunately somebody's pointed the finger at you and said go away and do it. This should be a bit of an MDT approach. I think what we've definitely suggested is that there are certain people that you wouldn't deprescribe first. So we don't want anybody necessarily with a severe mental illness and a pre-existing schizophrenia to be. So and my usual advice is do it as a bit of a team, do it with your clinical practice, go low and go slow. So you just do little bits at a time, go with people. But we're hoping that some of that is in the toolkit. Is there anybody who is from a PCN pharmacist who wants to? Is it Donna? Donna, did you want to come in about what might be useful?
It's more about being able to get the nursing homes, which is where a lot of the patients are, on board, because obviously they're the ones dealing with that distress. And we certainly find when we try to deprescribe for people in nursing homes, we don't know those patients because we're doing it from a desk. But there's a lot of kickback then from the nursing homes because they don't want things stopping, because life's easier for them if the patient is asleep all day. So having that template that is linked to proper guidance telling you exactly how to deprescribe, how to reduce, for instance, reduce dose by half for a month, then review. It gives us something then to push back to them. Certainly it's not something our GPs would really get involved in. So we're kind of on our own with that. So anything in terms of templates and toolkits that just allow us to document it clearly with what we've done, why we've done it, and what our plan will be would be really helpful.
So Donna, what I would say is that having done a lot in care homes, and maybe Anne, I know who works in care home setting as well, can advise on, is that some of it's about relationships and understanding why people are worried. Are they worried that, and lots of people have some really weird thoughts that suddenly everything's going to go a bit ballistic when you stop them. And so you need to know what they're worried about, because then if you know what they're worried about, you can address it, is the first thing I'd say. And I would get people on board by saying, we can always go back and we can always stop. And if we only just do it a little bit, and then we stick, like the card game, and then we go down a little bit more depending. So I take them with me, and the other people you need to take with your families, because everybody worries that you're going to end up having to make them move placement and all sorts. So it's about making sure that they know you're doing it for the right reasons, not because you've been given a job to do, but actually because you care about that person and about the risks. and you'll learn your own strategies to how to do that. But it's really about being really person-centered and making sure they know why you're doing it. Is there anybody else who's doing it successfully in care homes who wants to come in and give any just supportive advice there, add into what I've just said? Anne, is there anything else you wanted to add?
Yeah, absolutely. So I think there's something about making sure that the care homes do feel that you're not going to make that change and then disappear, that you're going to have an ongoing relationship with that care home and with the staff too. So there's a reassurance there. I think there's certainly quite a lot of education and training needed around the sorts of symptoms, the sorts of distress behaviours where the medicines, there is some evidence that they may help in terms of aggression, and the very many sort of behaviours where there is no evidence that they're going to help at all. So there's something there around the education and training to the staff. Certainly where I am, obviously the big issue for us is falls. And so there's something about helping care homes to understand, you know, apart from the antipsychotic, anticholinergic, there's also this issues around the falling. And so I think there's a few things that we can do really with that. But a lot of it's going to be about reassurance. And for me, certainly in our practice, we are not seeing as much analgesia as you would expect. So we're definitely seeing comments around distress in personal care and such like, where you would, you know, anticipate that there could be some pain involved, and we're not seeing the analgesia. So I think there's something around training clinicians to more or less assume that there's a degree of discomfort and be looking at paracetamols and such like, and I think there's something there as well. I've looked and I can see that there's people from East Lancashire on this call, and I seem to remember my fabulous team were being incredibly successful at stopping weaning people down and trialing without antipsychotics. So I don't know if there's anybody in that team there that wants to comment on what they've found successful, putting them on the spot there a bit.
I don't mind coming in.
Thanks, Vicky.
So yeah, we've had quite a lot of success in East Lancashire. I think the big thing, as Anne's just alluded to, is building that relationship and making them aware that you're not just going to stop a medication and they're never going to see you again. It's that reassurance that it is a slow and gradual process and that you will be there to support them the whole way through that process. You will be making regular contact with the home. They can come back to you if they've got any questions, any queries. The other thing I think is once they've seen it once and the potential benefits that can be realised from reducing the antipsychotic in a patient and how that patient's quality of life can be improved, the next time you suggest it, they're a lot more amenable to that suggestion, and once they've seen those actual real life benefits to their residents. So obviously from my point of view, I would never go into a home and suggest doing it on multiple patients, multiple residents at the same time. If you build the trust of the care staff as well, and sort of reassure them, if as I say, if they've seen it once, they can then feel a lot more comfortable in realising those benefits to a patient. So I think that it's all about relationship building with the care staff, certainly in my past experience.
Victoria, are you a pharmacist or a mental health nurse?
Pharmacist.
So that says to me that we can do some of this, and I think everybody thinks it's somebody else's job, as the saying always goes, but actually empowering people to know that actually you can have a strong place doesn't mean it is all your job, but it means that it can be part of your job as well. And actually I want to make every contact count across all professions. It's no one person's got to be landed to do it. Now, Karen, you had your hand up and it's dropped, but I did want you to be able to come in if you wanted to.
Thank you very much. I guess really I just kind of echoed the last two speakers really. I've been part of the project team in Doncaster whereby we've been really working up the multidisciplinary teams within care homes. So it very much is about they're not doing things on their own. It is about growing and learning together. We've got GPs who don't feel comfortable about doing some of this work, and actually our CPNs have been really kind of proactive and leading the way. And so we don't do things on our own, and it is a joint decision, and it is very much then discussed and written down and documented as a joint approach. But likewise, we've also got lots of training needs. We need to change our thought processes about how we offer training, and that we're trying to do things in joint approaches that then echo those MDTs. So again, very much saying what your colleagues have previously said, but we've just got probably a slightly different approach because we've really utilised the MDTs to support this.
Lovely, thank you. I've just seen, I think, Anne, you've got your hand up. I was just going to answer about, I think, Matthew, you've put, are there infographics? What we have is in the toolkit. There may be more out there. I can't remember, Delia, if there were any very simple infographics that you could use on a page. I love an infographic, especially for care homes. But if anybody has stuff, we can share stuff on the Futures platform that isn't in the toolkit now, with an aim to get it in the toolkit in a year's time. And if people haven't heard of the Futures platform, that's where we can share and have more of an online conversation after this. And it might be worth us putting a link to that, Colin, in there. But I can't remember if there's a single one. Delia?
I wasn't sure what you meant, Matthew. When you say what antipsychotics can do and what they can't, do you mean like what they're effective, what symptoms they're effective for and which ones they're not? Or is that what you meant?
Yeah.
Oh, okay.
So I'm a specialist pharmacist working in Harrogate and Yorkshire areas for TÜV. And a lot of what I see is not just kind of care homes that think medication is the answer for everything, but also a lot of our nurses and some of our consultants as well. Partly because of the influx of workload is so high. It's quicker to start a medicine than do all the other non-pharma stuff, and the OTs are swamped. So I think what would be useful is if there was a simple kind of picture that says, if you are distressed, antipsychotics have this % chance of reducing that. If you are wandering, they do it in this % chance. The actual efficacy in a simple kind of understandable way for care homes to say, oh, actually, this person's shouting out all the time. That at-risk spirit is not going to help with that, because this chart says, it does this in this many cases or something like that. Does that make sense?
Yeah, I mean, I don't know how much there is that, because the answer is, as I said, aggression is the only symptom that it does anything for. So maybe what we need to do is just go, Colin and I will, and maybe Delia will just have a look at what we've got. We can always put stuff on Futures if we can do stuff. There's some quite nice infographics in there around risk, how you communicate risk. And I know people like these things more or less than others about, the risk of stroke and death. I use them in some of my slide sets. I haven't put them in this. So there are stuff like that about communicating risk. It was interesting what you said about attitudes to prescribing. And there is an attitude survey that somebody doing a fellowship has put in that you can use at Place to try and work out what if people have forgotten the risk, how do they know? So you can work out whether attitudes is part of your place-based problem. And that's in there, that somebody did part of their fellowship, because I agree with you, and I'll be honest, I think that's part of our place-based problem. People have forgotten. They've forgotten the risk, and we're quite, we think the other, what we're trying to treat it trumps the risk, and I'm not always sure it does. Okay, so let's have a look at where we've got more hands up. There's none at the moment. And you put your hand down. Did you decide you'd had enough, or did you want to come in?
I think the conversation have moved on,
Okay.
but I'm happy to come in with a different thought. So probably it was just I was just refreshing on what Vicky had said, that it is very transformative when a care home experiences their residents starting to speak and interact with them when they previously hadn't been. And so I think that's a really positive take, that perceived anxiety, that their behaviour may deteriorate, when our experience was that actually people blossomed and they were able to relate and enjoy their food and enjoy interactions. So I think that having that positive virtuous circle really helped my team to kind of develop more confidence around that. And I also think it's necessary to say that this is a journey to sort of develop that competence and confidence. It's not the first thing that you know. It will take time for us to develop the pharmacy teams to do that, but it's definitely there. I think something that I might like to maybe start a discussion around is the polypharmacy. I know that on the previous call we talked about, there was a potential that people might move away from antipsychotics and move towards benzodiazepines or trazodone or whatever, when actually what I'm seeing is all three, is everything. And I know that I think East Lancs will probably have a comment as well, that for them presents a real big challenge when the community mental health teams, wherever they may be, are just throwing up the kitchen sink at it. And when that person develops agitation related to their benzodiazepine, for example, then they hit them with the antipsychotic. And so I think there's some sort of conversation to be had around that. I don't know.
I think you're totally right. We see it all the time. Don't do so and so, so let's start using a bit of something else instead. And I think benzos are my quite big worry, that we start to use that as the chemical cosh instead of antipsychotics. So has anybody got an experience of knock-on effects when they've tried to reduce, or seeing some of that effect going on in their own areas when they've tried to reduce antipsychotics or medication?
Actually, I was thinking, Sarah, not necessarily them reducing it, but that the person develops a side effect and then they are given the treatment, so it's not that they're reducing, that they're developing the agitation, it's that they've been given a benzodiazepine, for example, and then they're given the antipsychotic to manage that. So it's an escalation, it's that prescribing cascade that you can see, rather than, as a reaction to reduction.
I would hope that in the toolkit that you'll find some of those, some tools that will allow you to push back, because I think often I talk about anticholinergic burden a lot, and there's a look of complete sort of, I've not really heard of that from so many people. I'm so surprised. Not usually pharmacy colleagues, okay, but lots of other people have never heard of it. I think people have heard of stop and some of the frailty stuff, but other stuff is new, and you can see these little, light bulb moments. And I'm hoping that you'll find that section and those bits allow you to just gently nudge back to prescribers that just because you can doesn't mean you should.
I think the toolkit is a really fantastic resource, and I'm so pleased it's come out, because I agree with you that I think people are needing a reminder, and then they're needing this really practical help on what they should be doing. One of the things I know we've been talking about locally is perhaps getting some standardised communication coming out from our mental health colleagues that will sort of standardise and reinforce what NICE is saying, and also set out that expectation that this is short-term treatment, and sort of we're hoping to develop a kind of almost a template letter, if you like, and we're hoping that our expert colleagues will use that, because I think certainly locally we've really got a challenge in our hands of changing culture and not reaching for the prescription pad. And so we're kind of looking at all different ways that we might do that, but I think that could be an effective way, not only to keep reinforcing the messages to the GPs, but to reinforce the messages with our colleagues if we can get that up and running. I know we're quite excited about that, aren't we, Sarah?
We are. We've got a challenge in Bradford. Right, I've got Alex. I've only can see the first bit of your name. Oh, it's Alexandra, full name. Alex, what you thought?
Sorry, we're sharing the screen, so sorry about that. My name's Jo Hainsworth. I'm one of the older people's inpatient pharmacists in Leeds. I just wanted to make a little comment really and see if there's any work around inpatient discharge planning, because one thing that I've noticed as an inpatient service is we're quite poor at communicating on discharge what we're doing with antipsychotics. So is there any sort of tools that we can use to try to improve that? Because we try and document as much as we can as an inpatient service, but I think it's actually reminding the prescribers that actually we really need to be documenting what this is for, what the target symptoms are, things about monitoring as well. Monitoring is really often missed because the patient group are often antipsychotic naive as well. So looking at all those aspects, I just wondered if there was any work around that as well.
There wasn't a huge amount, which led us in Bradford to start, and it'd be lovely to have a critical friend to maybe to look at it as an external. So we're now working on 2 sort of template letters to add to the system. One will be new prescribing of an antipsychotic, and the other one will be about sort of ongoing, so that actually and what we're trying to all agree is the content of that letter, and a lot of it will be very much around documented risk and who's done it. So it's a bit of a reminder to people that this is your duty if you prescribe it, but also what you expect of monitoring or not monitoring. That's another whole little debate that I'm going to we're going to be having with some people, and maybe that'll be a lovely one to have you guys at some future conversation around what is appropriate, but I won't probably introduce it here. So it'd be lovely to be able to have a sort of a critical friend to show our template letters to that we're going to come up in Bradford, and then see whether that would feel appropriate from and whether you have any comments, and that would be lovely. We'll probably post it on Futures, and then ask for people to critically to feedback would be great.
That would be great, because one of the things that I worry about from an inpatient side is I'm writing all these things down and, have remember drug monitoring, review this, check for any symptoms. And we might have started some weird and wonderful medications. Actually, I worry that the rationale behind that sometimes gets lost. So it'd be useful to just link in and be able to have those conversations, really.
Because what we found anecdotally, not obviously from inpatient psychiatric units, but from acute hospitals, that things were started for delirium. They never intended it to be long term. Out they come. Nobody knows why they're on it. People think it's because something really weird and scary went on. Nobody wants to stop it. And it's like, well, actually, it was a delirium. The delirium is over. Delirium is actually really under thought of as a cause for distress. And that's another one that you really need to think around is delirium. And I've got some sections in the toolkit around delirium and some resources. It's an unknown, it's a forgotten reason for distress, acute distress, why somebody's completely different. Delia, did you want to come in? Because you're from an acute setting as well.
Yeah, I was going to say, so we haven't really got discharge planning as such, but we've actually added the deprescribing table to our shared care guidance. For dementia medication, or dementia shared care, because we had an incident where someone was on amisulpride for behavioural symptoms of dementia. They'd tried risperidone, got side effects from it, so we switched to amisulpride, and then we tried to discharge the patient to the GP, and the GP refused to take on the amisulpride. And it was only going to be for a few weeks anyway. They'd done well on it. We thought we'll keep it a few more weeks and then ask the GP to reduce and stop it. And we thought they were refusing because it's unlicensed in dementia. But when I spoke to the practice pharmacist, they said, no, it's because we don't know how to reduce and stop it. We're not confident stopping it. Therefore, we're refusing to take on the amisulpride. So that made us decide to put those tables, those deprescribing tables, in our shared care guidance that the GPs all have a copy of, to, so that they're more confident in reducing gradually and stopping. But it would be brilliant to have some sort of documentation to say why they're on it. Like you say, when it should be reviewed, what we've already done, what we've monitored, what needs to be done. So yeah, we haven't got anything like that from an inpatient discharge.
One of the things we're going to put in our letter is exactly what symptom am I trying to treat, because that will also concentrate the mind of the prescriber. What is it I'm trying to treat? Actually, is there any evidence that this drug treats that? So yeah, it's going to be in, but we'll be delighted if anybody can feedback about what they think and if there's additions. There is somebody sent it to me following the first webinar, and I think I've not managed to send it on to you yet, Colin, and I couldn't find a link to it. There is an Alzheimer's Society template for prescribing of antipsychotics, not necessarily discharge from acute settings, and I used that and I sent it on to my group. But I couldn't find a link. I tried to Google it to try and find out where it had come from, and I haven't managed to get back because it's just been manic since we did the launch, to find out where they got it from, because that was quite nice as well, because that really concentrated on minds what risks and why you'd prescribed it. So we're going to try and share that. Delia, you've got your hand up. Did you want to come in with some more bits, or is there any other? A legacy, don't worry. I'm still half mute half the time. Legacy hands, 2 years in. Any other comments from anybody? Anything else they'd like to share before we just have a look at what's in the
Sarah, there was just something in the chat that I don't think has been covered about whether people need any specialist training for deprescribing.
So do you need, that depends on who you are, all right, what you normally do, how confident you feel. So to me, what I would suggest is that if the whole thought leaves you completely scared, then yes, you do. If you do this all the time and you've been doing it before, do you need any extra? No, you need to use the same principles that you use normally. Go slow, do it gradually, get people on board. So if you're used to it, no. If you're not, yeah. And then I would say, and I would go back and say to my system, my place, you know, being on the launch, thinking about deprescribing, what are we doing? How are we going to support each other to do that? I don't know if we looked at any specific, whether there's any e-learning or anything else specifically around deprescribing. Anybody from a pharmacy background who knows if there is deprescribing e-learning and stuff? Maybe on the Royal Society of Pharmacologists, is that the right one? I don't know if I know Prescript, we put some stuff in there that they've got some stuff, but I can't remember if there's any e-learning. But I would get together at Place and actually use your senior support and knowledge base to do it that way, rather than say and work out whether you feel comfortable with it. Victoria, have you put Prescript because you think that they've got some e-learning?
On general deprescribing, yeah, I'm
fine.
99% certain that they do. Yeah.
We've been doing this toolkit for so long since I've read all the resources that I can't remember what's in there, I'll be honest. Fine, so that's in the toolkit. Somebody's put, can you share the shared care guideline? It's moved up the template. So somebody put, can you email me? Everything you should need is in the toolkit. Everything we found. There is the odd thing. The East of England's guidance isn't in there because we're having a little discussion around the word monitoring, but that might be in the next iteration. But other than that, mostly stuff you need is in that toolkit. Is it Kate?
Yes, it is.
I've not seen that spelling, Kate, before, so that's really interesting. I love that spelling of your name. Tell me what you've heard about the Academic Health Science Network and what they're doing.
So I think they developed this in the Isle of Wight and Wessex as a three session training package aimed at SMR, people who deliver SMR in PCNs. So it focuses on polypharmacy and deprescribing and how to support that. The course has a entry requirement that you need to have been a prescriber, I think, for 2 years before you can go on the course. And at the moment, they're going through a process of getting it commissioned through ICSs and doing a sort of train the trainer session or sessions. And then those trainers will then deliver it across their ICS.
Fantastic.
So it's a potentially national program providing Academic Health Science Network can sell it to their ICSs.
So we'll follow that up as a link, because obviously we don't want to send you to something where you have, well, it's all right if you've got some money and you can pay for it, but most of us probably don't at system, but we'll look at that. And I can also see, Melanie, you've put a link in. Do you want to tell us a bit about your link? Is this something you've used or just something you've found? Melanie Aston? deprescribing.org. So if people can see, she's put a link in the chat box. Maybe Melanie, you might have gone, or you're not off mute.
Her microphone's not working.
Oh, microphone's not working.
Oh, okay.
Don't worry. So I can see, Melanie, you've put, so if so it's just something you've found, so it's worth people exploring those. And if you do have stuff you think actually that's amazing, we want to put it in the next toolkit, then yeah, absolutely, we will do that. So we want to make it as useful as for people as possible. Heather, did you want to come back in?
I just wanted to say something about the AHSN. So those action learning sets are available for any prescriber in primary care who's been prescribing for more than 1 year, and it is available nationally to colleagues. So there's a number of dates available, and I think the next one starts on the 9th of November. So you basically, they're 3 half days, and there's a geriatrician involved in the last one as well. So GPs and anybody who's been prescribing for a year. Just saying, from a West Yorkshire perspective, we have pushed back to the national team and challenged them about that 1 year bit, because I think it's stopping people who need this training from accessing it. So that's the conversation that West Yorkshire are taking back to the national team. But Claire Howard is the link. So if you want more information or want to share it with this group, she would be the person to contact. She's the national lead for that programme.
Yeah, that would be amazing. And Colin, shall we follow that up? Because
yeah.
I agree with you, Heather. I think good deprescribing should happen at the same time you're learning about prescribing, because otherwise you get into the wrong model of way of working.
Can I just ask Heather, have you got an email contact for Claire Howard that you could share with me?
Yeah, I'll share it with you, Colin. Yeah.
Brilliant, thank you.
Okay. So we're coming to the last 5 minutes. It is a different focus of conversation, so I've been delighted to talk to you today, and it sounds like we're going to have loads more things to think about for the next iteration. Is there anybody who would like to add any more comments or questions in before we start to wrap up and call it a day?
There's just one question in the chat, Sarah, that's from Matt about how long mental health trusts prescribe antipsychotics before transferring to primary care.
So how long is a piece of string is the answer to that, because they'll all do something differently. And so this is where your place-based audit data might come in. So we've started to do this. We've had 6 practices reports, so very early days in Bradford, and we're finding quite a lot of it is coming from our acute care colleagues, the mental health colleagues, and they've just discharged on it. But it's very variable. So I suspect it's when they feel the behaviour is manageable, or the distress. So let's change reframe it, and then the discharge. But it will be very variable, and that's probably a conversation that I would have at place and find out what. Just ask that naive question: what are you doing, and what do we do? What's our plan? I can see that somebody else has just got. Was it? Just a minute. Was somebody else? Was it Aisling?
Right. Yeah, Aisling. Yeah. Hi, Sarah.
Aisling. Hi.
We haven't met yet, but I think we're supposed to be catching up with yourself and Claire. I think I'm sure we've had a conversation with Chris Farnell.
Oh yes, we have. Yes.
Yeah.
Oh, are you from the
Hi,
East
Delia.
of England network? Are you from the East of England network?
Hello.
Yeah. So I just wanted to come on and say hi. Sorry, I've kind of jumped into this session, but I really thought it would be interesting to find out what the barriers are for PCM pharmacists, and I suspect I should probably join the mental health provider conversation next week.
All right, you can listen wherever you want.
We've been doing a bit of scoping, so our pharmacy service is really new, supporting the community mental health teams. They've not had that before, and as part of our scoping, we've found from team managers that a big concern they have is that there's no medication formulation section on the discharge care plans to primary care. So I'm wondering, is that having an impact then on our prescribing rates, possibly indirectly. But if there's no advice then for primary care clinicians on how to follow up the medication, you know, it's a no-brainer. So we're going to be doing a piece of work with them to try and get those care plans reviewed and at least have some prompts about medication.
Yeah.
So it would be really good to hear from the local medicines optimization team any ideas for what they would want to see in a care plan coming from our team to primary care.
So what we were just saying, we're developing some templates letters at the moment.
Yeah.
And we've already decided we can't do it by email because it's
really hard.
We're going to have a little task and finish group because we've got quite different views. So we're going to meet up and do that. We all love each other, so we'll do it nice and respectfully and nicely. But yeah, we'll share those once we've got a rough blueprint with anybody who'd like to comment and give us help with that, because that would be really helpful, because I think that is a lot of it. We don't communicate with each other.
Yes.
And what we found anecdotally is we think somebody else is doing it. So the acute care colleagues think it's all GPs think it's all them, and the answer is, at our place, it's actually it's not clear cut. It's actually coming from a little bit from everybody, the prescribing.
Yeah, absolutely.
Okay, so we're into our last minute. Can I just say thank you everybody for joining? We're delighted to have you. It would be lovely if we have other bits that we want to have a conversation about. It's really nice that we've got, you know, there's been 65 people on, a bit of a forum. At some point when Delia and I have had a conversation with our colleagues from the East of England, we might want to talk about monitoring and what we all feel about it, because that would be a really useful one to get a bit of a steer. And then we can feed that back into the national team about, you know, and actually do we need to have those conversations with the colleges about how we monitor drugs. So that might be one that I'll call you back to at some point. We will send out, we'll make sure you have a copy of the toolkit in the, and also do have a look for us on futures. If you can't find us, then email Colin, we'll send some instructions out. And let's continue the debate there. So have all have a good afternoon and lunch break, hopefully. And if you want to join any of the other conversations in the next few weeks, please do. So thank you very much.